So I will be presenting an overview of the latest measles outbreak in DRC. Five main lines. We'll talk about the background, but I'm sure that many of you are quite familiar with this issue. And then I will tell you about the MSF intervention in 2015. We'll talk about the additional data collected with the Epicentre survey and additional insight based on modeling made by Matthew's team before talking about the lessons learned and before opening the actual discussion. So DRC is one of the biggest African countries, and it has a population of 70 million people, and it is an endemic country for measles. Infrastructure is really poor in this country, making that immunization itself is a real challenge because of logistics problem. The main outbreak in 2010-2013 reported 300,000 cases, started in Katanga before spreading across the country. This this has led to a massive reactive vaccination campaigns supported by MSF. You can see the figures on the right with a narrow or brackets showing the peaks. The latest outbreak was also in Katanga. This is showing the epidemic data for Katanga 2015. On the left, you see the 4 provinces of Katanga that have reported, and on the right, you have the age groups distribution. Holomami was the hardest hit with 25,000 cases out of the 40,000 cases reported, with the Tanganyika with 12,000 cases. Another important piece of information is that some 25% of the reported cases were aged between 12 and 59 months. This is the geographic distribution of the outbreak as 12, so weeks 12. It started in Lumlani, which is the darkest area, and then gradually spread across the neighboring health zones in the second wave of the outbreak before being more scattered towards Tanganyika to the northern eastern part of the country, which is becoming darker and darker before declining towards the end of the year. When it comes to MSF support on the left, so you have the attack rates observed in the various districts and an icon for each of the health zones supported by a section. And you see that the most affected health zones have had support from at least one MSF section. The right-hand side map is easier to read with the same color code throughout the presentation. In blue, you have MSF France, purple MSF Geneva or OCG, and then orange is OCA, and then the last one in a browner area is Spain. So 16 health zones have been supported by MSF, and 23 health zones had vaccination, sometimes only with MSF or with partners, with Alima or others. The support was there for vaccination, but also case management. No, more specifically, if we consider per OC, you see the ones that were supported by OCP here, mainly in Olomami, which was the hardest hit province, and the first one hit, actually. The blue square represents the time of presence of OCP in the health district, and in red it's showing the beginning and the end of the vaccination campaign. Wamba, Male-Balkulu, and Mukanga had vaccination before the natural decline of the outbreak. And we see that the number of reported cases on a weekly basis really dropped after that. Now, more peripheral areas, less affected, also enjoyed some support from OCP. OCG supported the two health districts that were the most affected in Katanga, Ankoro and Manono. Ankoro, here again, you see the number of cases dropping after the intervention. OCA was present throughout the year in Kidonja and Kiambi because of its usual program, and supported additional support in Mitwamba. MSF Spain, OCBA, covered 3 health zones in the eastern part of Katanga province. 4 vaccine coverage surveys were made by Epicentre in the dark gray area, so that was after the OCP vaccination campaign. 2 retrospective mortality surveys in red and 4 seroprevalence in green, and I will be presenting the results. Starting with the vaccine coverage, the percentages were rather high, more than 90% and close to 95% for Malemba, Kulu, Luamba, and Mulongo, and slightly lower, around 80% for Mukanga. For the retrospective mortality survey, one sees that the overall mortality was rather high in Malemba and Mukanga, and children under 1 were the most severely hit, whether for the specific or overall mortality. We also have the malaria-specific mortality, which was at least as high as the measles-specific mortality. This is showing the mortality by month for children under 5, with the 2 areas, Malemba and Mukanga. This box shows the presence time of OCP for case management and vaccination alike. And in Mukanga, the mortality curve went down, even though the rates were still high. And for Mulamba, it's not the same. The overall mortality was still very high. When we consider the measles-specific mortality by month, we clearly see that the combination of case management and vaccination has helped to curb down this mortality curve in both areas. When comparing these measles-specific mortality cases and the reported cases of outbreaks, we see that it really goes down after vaccination, which was also combined with case management, of course. Matthew Ferrari's team has used the latest DHS data. From these data, they've made estimates on the left side for the vaccinated coverage for children from 9 to 16 months, with the red the areas with the lowest coverage, and on the right-hand side, the number of unvaccinated children. When comparing these maps with the map that you've seen for the attack rates, you see that the collected data before the outbreak faithfully describe what actually happened. The Tanganyika and Olomami neighboring areas have the lowest vaccination coverage. And when we consider the number of unvaccinated children in absolute terms, you see that Olomami, the most affected area, had the highest number of unvaccinated children. Another interesting figure is the age distribution. You see Ethiopia on the right-hand side, a country where the API is higher than in DRC, where the age distribution is more even. Even adults are hit, but you have a much lower number of children. And then you see the cases for DRC from 2004 to 2012, the scale of the country, where it's quite heterogeneous, where some provinces have a rather good vaccination coverage, not so much for others. So it's intermediate compared with Ethiopia, but the age group of children is much greater. And then you have Katanga in 2015, that is the extreme left, and that's also extreme case example with a very high number of children hit, and which shows that the age groups is really showing an extreme compared with Ethiopia. So that's really a very low vaccination coverage for our children. Now, the lessons we've learned from this surveys is that MSF has supported the most severely affected health zones, both in terms of mortality and attack rates, that the overall mortality rates in the health zones were rather high. The emergency objectives and the strategies involved and used by the various OCs were rather different. In some instances, they would focusing on decreasing the number of cases and the mortality rates, while for other sections, it was more an overall objective to decrease the overall mortality of children under 5. And this has meant that the vaccination campaigns targeted specific age groups depending on the health zones. Another lesson learned is that some reactive campaigns appeared to have decreased the number of weekly cases and the mortality rate, even though the vaccination was supported by additional case management, which would suggest that the overall operational strategies should be adapted as a function of the outbreaks, that is, when do you arrive in the health zone in relation to the beginning of the outbreak and the context, because not all the health zones were the same. And when we consider the modeling data, of course, it was made after. The modeling was made after. It seems to show that the EPI coverage is rather low and that there are pockets in the regions of children who are not covered, which would likely explain the 2015 outbreak. Thank you.
Merci beaucoup, Alex.